Okay, y'all. As promised, we're going to do a review of electrical stimulation here. So, what I'm going to do just for time is break this down into just each individual PowerPoint. So, you'll have one PowerPoint for the intro e-stim, one for the neuromuscular, and one for the one we did for pain control. That'll make it a little more palatable. And this will serve as a review for both just overall, overarching, just to give you those little tidbits through the PowerPoint that maybe we didn't get a chance to get to in class, and also a quiz number 5/6 review for your eSTEM quiz next week. So we're just going to run down this. I'm not going to spend a huge amount of time on it, but maybe give you some background info or just a refresher. So we'll start with the electrical stimulation PowerPoint, just the introduction. eSTEM, knowing where the electrical current comes from, that's all fairly basic. Understanding that there's an excitation of the action potential, we'll talk about that, and that excitation comes from the sodium-potassium pump. So there's a switch between positively charged and negatively charged ions inside and outside of the cell, of the nerve cell. So that's what we're working on when we're looking at eSTEM is excitation or production of action potentials within the nerve cell via the sodium-potassium pump. So nothing crazy here. I'm not going to get super in depth on the cellular activity in terms of ATP and how the responsibility of the sodium-potassium pump in terms of how it needs to fire and how it's excited using eSTEM. But one thing I would know is that there is that when we introduce an electrical stimulation, there are different excitation levels for different types of nerve fibers. So we'll talk about that more, but I think if you remember, you're going to see that graph in a little bit. And just knowing that you have a resting potential for every type of cell that involves the permeability of the positively charged and negatively charged sodium and potassium ions. And so reaching and activating each cell, you have to reach a different level of excitation depending on what type of cell or what type of nerve fiber that you're working with. So here's just the definition of action potential, and just knowing that you need to have sufficient stimulus to activate the action potential for that particular nerve. And again, that will go for, like, that's the difference between how much excitation is required for an A beta cell versus like a motor neuron, right? Let's see here. So the action potential, just defining it, is the basic unit of nerve communication. There are also refractory periods involved with that where you get sort of this all or nothing response where it goes up, you've reached the excitation, you've reached the action potential, and there is no further excitation beyond that point. Same thing as you get to a place of direct depolarization where once you have reached sort of this lower end of the sodium potassium pump where you've now switched back and effectively turned that cell off, there's this refractory period where the cell can no longer fire after a given time. So that's just the basics here. This is the big one, right, guys? I want you guys to know this. This chart is going to be on your quiz, so hint, hint. So being able to interpret this chart is important. I'm going to go back through and try and explain this a little bit like we did in class. So it says right here, in order to produce your action potential, you have to have a significant amplitude and duration of the electrical current, right? So I need that wavelength to be, the intensity to be high enough to reach that action potential, and it needs to be applied long enough to be able to reach that action potential. So every different nerve fiber, depending on the type of nerve, is going to have a different rate of excitability or a different action potential that's required to be able to excite that nerve, right? So that's what we talked about. So lower currents and lower pulse duration. So the lower current intensity or amplitude and a smaller pulse duration, like we're seeing here in microseconds. Now this one uses all the same, right? But it's going to max out roughly here on this graph, but what you'll see is it's a lower current strength that is required and a lower duration in terms of that electrical impulse is required for different things like sensory. So sensory activation requires less overall energy, less electricity or amplitude intensity for a shorter period of time, right? In terms of your duration of that pulse. So we can see here the first thing that we're usually going to catch is your A beta sensory, right? That's vibration, mechanical pressure, things like that. That's what we're looking at when we're doing TENS, right? That's what we want to activate that A beta sensory fiber so that we can work on the gait control. Then a little bit as we increase to some degree our higher current and a slightly higher pulse duration. Here we're looking at just between 40 and 100 milliseconds or microseconds rather. You're going to start to catch your motor neurons, and it sort of ascends in that direction, right? So we've got then the A delta sharp pain neuron or nerve fiber, those peripheral nociceptive nerve fibers catching in a little bit. So again, going back through this, we just need to know that different types of neurons are going to have different levels of excitability. And in order to reach the action potentials for those neurons, we're going to have to manipulate our parameters. So in a nutshell, guys, this is how eStim works. If I'm trying to catch the sensory neuron, just like I would with TENS, right, where you're just trying to achieve the buzzy tingly sensation, I'm going to really only try and fire these A beta sensory neurons. So I'm not going to have a long pulse duration, and I'm not going to have a super high current level or amplitude, frequency, whatever you want to say. If I'm trying to activate a motor neuron, I'm going to need to ramp up that pulse duration, and I have to increase to a certain extent my amplitude or frequency in order to catch that neuron. And you can see that reflected in the charts that we worked with on lab last week. So you're seeing the disparity where you've got a low rate TENS that's sitting at 50 to 80 pulses per second, which isn't that crazy, and a lower frequency, usually I think between 100 and 200. I don't have the chart in front of me, where the difference is when you're trying to activate like an NMES, we're going to have to bump up that pulse duration, right? Usually over 100 to some degree. And then we're going to have to also add in probably a little bit higher frequency in order to affect and enact the motor neuron in a way that's going to force a contraction like we did in lab. So that is the fundamental basis of what we're doing with eStim. So definitely know those things for your quiz. Like I said, this is going to be on your quiz, this exact graph. And the reason why this happens, as we discussed before, is that action potential is going to travel faster in large diameter myelinated nerves and then in smaller diameter unmyelinated nerves. So that's the difference between what we see. Let's just use our nociceptive inputs here. So there's your A delta, which we know is myelinated and very quick conducting, right? So you're looking at maybe up to 5 milliseconds or meters per second, compared to our C fibers, which are that dull pain unmyelinated, which operates maybe at 1 meter per second. So the transfer rate is different, and because of that, we're going to have to change the type of electrical impulse we use or the parameters of that impulse in terms of wavelength, duration, frequency, that sort of thing, in order to affect those different types of nerves differently. Okay, so that's the big takeaway from this. So here you can see this, and this again, this here is the sort of the science of it. But if you go to your chart, it's going to make more sense, right? Sensory stimulation, TENS unit, right, is going to live between pulse rates of 50 to 100 microseconds because, and if on your chart you'll see it's 50 to 80, because that's the action potential or the excitation required to reach the excitation or the action potential of that sensory nerve or that sensory input. So that's why TENS lives between 50 and 80, because that's what it takes to fire or to excite that neuron. Motor stimulation, we change the pulse rate from maybe 50 to 80, where we're trying to hit our sensory, to 150 to 350, sometimes even higher, right? Because the action potential for the motor neuron is higher. So we need to adapt our stim, increase our pulse rate or our frequency in order to affect that particular motor neuron and get a good quality contraction for our goal of treatment. And then same thing here is denervated muscles that no longer have that communication system operating, right? So it's like the example we used in class where your internet connection, right? Your internet connection is slow, it's fast, it all is variable. This one, we're really, for a muscle like this, we have no internet connection. So we almost need to make our own hotspot, right? That's a terrible analogy, but hopefully that hits. We have to increase our amplitudes and increase these huge long pulse duration, because we're trying to restore a system that's fundamentally broken, whether it's spinal cord injury or some kind of neurological deficit or dysfunction or disease process. So now we're trying to solely use our external electrical impulse to fire a muscle that no longer can fire for itself. So in order to do that, we've got to really ramp up. I mean, we almost need to jumpstart this muscle if you think of that, right? The battery is dead, so now we got to put the breaker cables on and try and bring it back to life by increasing or introducing large amounts of electricity. So this is just the rise time and the fall time, rise and decay. This won't be huge on your quiz. Let me see. It does have to do with accommodation. So I do want you guys to know that changing the pulse interval, changing the duration, changing the peak current, and some of the things that we'll see later on in terms of like burst or modulation are built in to change the type, the rise and decay, and the type of wavelength that you're going to see in order to prevent against accommodation, right? We're trying to keep the nerve confused so that it doesn't just accommodate or get used to that stimulation over time, and we can have more prolonged benefit with our use of E-stim. So here's accommodation, right, in a nutshell. If the current rises too slowly, or if the nerves are continuously or repeatedly excited, they're going to adapt to that stimulus and become less responsive, right? This is the example we used in class, where it's like, as any parent knows, if your kid's trying to get your attention, they're going to tap on you, mom, 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 right? And eventually, if you're on the phone or whatever, it's going to get your attention and you're going to be excited and then you're going to respond to that stimulus. But if the kid only taps like once or twice, it's not going to be enough, right? If they're just like, mom, you don't even hear them, right? You're just going to keep doing what you're doing. That's what the nerve cell does. But if they continue, like, let's just say to cry wolf, for instance, right? So it's like mom, 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 mom. And it just never stops. And you respond and then you respond and you respond. Eventually, you're going to get to a place where you just ignore them, right? Because it's like, you're just bothering me too much. So it's sort of this Goldilocks parameter where you have to introduce enough stimulus to keep the excitation of that nerve, or the stimulus is going to keep that nerve involved, right? But you can't have it last for too long, or you need to do something to change parameters so that it doesn't adapt to it over time. So that's a combination. And that's what you'll see with TENS or any other thing, right? If you continuously use it over and over again. So how do we adapt or defend against accommodation? Well, we can change the parameters of what it is we're doing, and we can modulate them. And this is your modulation mode on TENS. So how does the TENS unit modulate? Remember the little M that's set up? That's modulation. We can modulate the intensity, that is to say the amplitude, right, of how tall each wavelength is. So it could be this many milliamps, then it goes down to this many, then it goes down to this many. So the intensity keeps the nerve guessing, is one way to keep the nerve guessing at least, because you're introducing different levels of electrical stimulus, so it never really knows what's going to have to respond to. The other way we can do it is by either decreasing or increasing the pulse duration, right? So if you remember, our pulse duration is just the width, how long that duration, how long that pulse lasts, that individual singular pulse, right? So we can change, maybe have a really quick pulse, and then have a long sort of protracted pulse, followed by another quick pulse, then a medium pulse. So changing and interpreting, or adapting that pulse duration is going to change the interpretation on the nerve side, and we'll keep it guessing. The other thing we can do is change the frequency, right? How many pulses per second, or in a given time period, right? So 3 pulse per second, 5 pulse per second, 100 pulse per second. Or we can modulate it and say, okay, in this second you got 3, then we got 10, then it's 2, then it's 15. So that's how you modulate. When you set the modulation mode in your TENS, it's going to tweak and sort of roll the dice in terms of introducing new frequencies of pulse delivery. So it's another way to sort of keep that nerve guessing. And this is a good one. So what do we use E-stim for? You guys should kind of know this by now. We're going to use it for different types of E-stim for different reasons, right? So we've got TENS, that's your transcutaneous electrical stimulation. You've got IFC. These are primarily for pain management, pain control. You can also use acutely IFC for edema control. And for chronic conditions, you can use your NMES, but it's more of a pump action, right? You're going to get some mild muscular contraction, and we're using the NMES in order to force small level contractions to pump or to push edema out of the area we're trying to impact, right? So stimulation for edema reduction, enhancement of overall circulation, and then hopefully range of motion enhancement or restoration. Whoops. Strengthening and muscle reeducation. So that's the big one. We went over NMES, right? We're trying to actually facilitate muscular contraction. Usually we're trying to do a couple things. Most of the time, we're trying to restore proper function to that muscle by asking it to work and combining it with some degree of strengthening. This is the Russian, for instance, right? Russian stimulation placed on a quad with a quad set or short arc quad, right? So this is stimulation of innervated muscle to restore muscle or function of that particular muscle, or also reduce guarding or spasticity or prevent against atrophying. Or also with a functional electrical stimulation. These are the devices sometimes we can use. Functional stim can be a device. I can also use common neuromuscular electrical stim in the way that we know it while a patient is doing a functional activity if I want to fire a certain muscle group, right? So if they're having trouble coming to extension and they have a job where maybe they're going low to high, right? They're making a lot of ground to overhead transfers. I may neuromuscularly stimulate their paraspinals to give them good engagement, good core engagement, so they can make that transfer properly with the right kind of muscular response. And then high volt, we talked about a little bit. This is more or less for tissue healing. That's that high volt pulse current that's going to come through. You've got the positive and negative monopolar setup. So we'll discuss that a little bit more when we get to it. But this is a good chart to know. Make sure you know this stuff for your quiz. Obviously, I'm not even going to spend too much time with this. These are going to be the contraindications and precautions for most of your electrical stim, regardless. So you guys already know, right? Broken record. You got to know this. This is definitely going to be a quiz. It's going to be on your final. This is like bread and butter stuff. So know those for sure. And also knowing the adverse side effects or the adverse effects. So understanding what you don't want to see in certain scenarios. So we definitely don't want to burn the patient. We want to make sure that we're conscious of potential for burning, skin irritation, overarching pain. Like if I'm catching too much of those A delta fibers, I'm catching too much of those C fibers. I'm not trying to enact pain. That's not the point. There might be some discomfort with this, as you guys have experienced with the NMES, right? Where I'm just maybe slightly pinging those A delta fibers when we're ramping up our Russian stim and you're forcing contraction, but it shouldn't be overtly painful. This is how we know our treatment parameters is just the basic application technique for E-stim. Understanding the different types of electrode setups, right? So the differential between monopolar, bipolar, we'll talk about here. The monopolar setup is what we think of with our high volt. It's one channel with one lead in the field, small electrode in the field of treatment, and then the other electrode is a larger dispersive electrode in a more remote location. So this is, for the most part, high volt and iontophoresis, right? We didn't really get a chance to show you that, but I'll show you that next week. But ionto for edema control, this is where we're going to use dexameth. Talk about that more in a different slide. But the smaller lead becomes active. The other one is just there to basically absorb the electrical impulse once it's been delivered. Bipolar is your standard, right? It's one channel with two of the same or near the same sized electrodes. And then quadrupolar is just two channels with four leads with the same or nearly the same sized electrodes. So when you're thinking quadrupolar, you're kind of thinking IFC, right? Cross-channel stimulation. These are the type of electrodes. I don't worry too much about this. You're going to see, just know that the electrodes are there and that we have to take good care of the electrodes. So otherwise you could have adverse effects, right? If the electrode is broken down or it's not cleaned properly or something like that, you can end up with either burns or pain or one of those things. So just know that. These are the type of electrodes. Not super, you're going to see all these probably in the clinic. Definitely your typical adhesive electrodes are going to be the standard electrodes that you'll see. Do remember, I think you guys have got this down for the most part, that you're going to have differentials in your current density depending on your electrode size. So the current density is going to be greater in a smaller electrode than it is in a larger electrode, because the same amount of energy or the same amount of electricity is being delivered in a smaller surface area, across a smaller surface area. So by that very nature, it's going to be more compact and delivered in a more centric way, rather than over a large electrode where the electrical energy will be dispersed over a greater area, and that will decrease the current density. So this is a good picture to use and to see. You may see something like this on your quiz. The other big part that we discussed is how you space your electrodes, right? So in terms of depth of penetration, you need to, if I'm working in this example, like I'm working on a big beefy quadricep, right? I have to, in order to get enough depth of penetration, I need to separate the electrodes far enough so that they're able to reach more deeply into that tissue. If I place them too close together, I won't get the depth, and a lot of the time you won't get the fullness of contraction if you're using NMES. So considering that based on the size of the muscle that you're working on, a close together setup may be just fine if I'm trying to fire my forearm flexors, right? And I'm working on the common flexor tendon, because there's really, I don't need to go super deep, and the muscle groupings for the most part are fairly small by comparison to some other ones. But if I'm working on a big back or a leg or something like that, I need to go ahead and space those electrodes apart so I can hit a deeper level and activate that muscle properly. So we learned about the motor points. These are just advantageous points that we've seen with our graph that I gave you the chart for, where it's just they did an experimentation, and it was decided that there are specific points within the muscle that can help to prime full contraction more readily. So just referring to your graph there won't be a lot on motor points, but just knowing that that's what they are and that's what they're there for. Flow of electrons, yeah, nothing super crazy here. Terminology, the cathode and the anode, this is going to be in really when it comes to like a monophasic setup, right? So iontophoresis and high volt, where whether you're using a negatively charged cathode or a positively charged anode is going to affect or attract or repel, like in the terms of iontophoresis, different ions of the same polarization, right? So we'll discuss more about ionto, but understanding what cathode and anode mean and how they're used in the realm of electrical stimulation. We'll discuss that more, like I said. Ooh, Ohm's law, too sciencey for me. I don't really care. I guess, that sounds bad to say, but just knowing that there's a relationship between the current flow, the voltage, and the resistance, and that by affecting one, you're affecting the others. But this is not science class, guys. This is PTA. All right, waveforms. Definitely knowing the different waveforms in terms of what, more or less in terms of what specific electrical agent is going to use what kind of waveform. So for instance, like iontophoresis is going to be a direct current waveform setup, right? And you're thinking, because it's a battery pack, right? So here's the picture of it. There's no modulation. There's no biphasic component to this. It's all just one straight up waveform. The battery goes on. It delivers a standard stable current for the entirety of the treatment. And then when it goes off, it just goes away completely. The other thing we might use this for is denervated muscle. Again, we said that we have to ramp up our intensity. We have to ramp up our duration. So a DC current is a good way to do that, because there is no phasing. It's just straight up electrical impulse until it goes away. So just know what that is and what it's used for mostly. Alternating current is what we see for most of your stim, especially our interferential current, right? Alternating current just means that it changes polarity back and forth equally. So you've got these sort of ridges, and it ebbs and flows from positive to negative and back again. And these are typically used for pain control and for muscle contraction. So that's what you'll see. And this is where you start to get, obviously, with a DC current, right? We don't have like a phase or pulse width or a pulses per second, because there are no pulses, right? There's just straight up intensity. We're setting it to a certain level of milliamps. With this, we start to get a little bit more in the way of our parameters, and this is why we can tweak things with these AC currents, because I can change how long that pulse is, or I can change how many pulses per second. So understanding AC current and what we use that for. And interferential current, we'll talk more about this in the next one we get into pain control. But IFC, we're using two medium frequency alternating currents. We're crossing them, right? This is Ghostbusters. We're crossing the streams in the middle to create almost its own individual current between circuits 1 and 2, and that will impact the depth of our treatment area. And again, we'll go over this a little bit more later. But that's what that looks like. We create sort of a new single current with the use of the two. Premodulated is the same thing, except we're now just using a bipolar setup. So instead of 4 pads, we're just using 2. So it's a single circuit and 2 electrodes, but it's creating a modulated current between those. So there's your pulse current, right? Could be monophasic, which just means it stays in one level of the polarity chart or on the amplitude. It could be biphasic, which means it alternates between negative and positive, right? So that's your pulse current. We'll use pulse current for sure in a monophasic pulse current setup where you have like a high volt. Again, this is you have some polarity acting like a monophasic PC. You've got a polar change, but it's used mostly to act on the ions one way or another. There's no significant biochemical effects because it's not a singular DC current where it's on just in one way. When you have it pulsing back and forth, it gives a little bit of a rest time, so you don't get as great of a let's just say chemical response. But you're thinking monophasic PC for high volt for sure. Biphasic PC, there's no charge here because it's symmetrical, right? We're getting just as much positive input as we are negative input, so the two cancel out. And this is variable muscle stim, but you don't really have to worry about that. Biphasic PC is going to be typically what we think of when we think of electrotherapy. So it's biphasic, there's no charge issue. It goes from positive to negative back and forth, and the current pulses some kind of way. So how many pulses per second, how long, or the pulse duration. So that's our most commonly used waveform. Here's a rectangular waveform, but you can see it's going to have a positive and then a break and then a negative. And then our time from positive to negative is going to be the pulse rate, or between full pulses, how many pulses per second, and the phase duration, or the pulse duration, is how wide that pulse is. So I don't want to confuse you too much. We'll go back over this later, but polyphasic PC is rushing currents, and this is like where you have crazy alternating currents, and then you've got like a break. Russian, again, was developed with very specific parameters in mind. Here they are. So you've got a carrier frequency of 2,500 hertz. That's standard across the board. That's why you can sort of plug and play every, on your machine like we do in class. And they burst 50 bursts or 50 pulses per second. And then you have a 10 microsecond long burst with 50 bursts on and 10 seconds off. So that's why you have that set up as well with your on and off time in terms of 50 seconds off, 10 seconds on, plays into rushing current. So we'll talk about that more later. DC current, equally through the stimulation, alternating, just understanding these and the components of these, right? And how they apply in terms of your parameters. And we'll get more into that when you get to specific electrical stimulations. This is the big difference, right? We'll go back over this one more time, but phase duration, right? The phase duration is the period of time when the current flows in one direction measured in microseconds. So here's a phase duration. We don't really talk too much about that when we're setting up our eStim parameters. So that's just a single phase, and again, like sort of how wide it is, how long that phase lasts, compared to a pulse duration, which is the time between the beginning and to the end of the full phase, also measured in microseconds. So that's the one we're used to. That's the one we're going to adjust on our stim, is the pulse width or the pulse duration, how long that individual pulse lasts, the entire pulse. So if it's just monophasic, it's just one hump, how long that lasts. The phase duration and the pulse duration may be the same. If it's biphasic and it has to go positive and then to negative, it's measuring how long it takes for that entire process to happen. Okay, that's your phase duration. That's your pulse width. That's what we manipulate. Interpulse interval is mostly to do with your number of pulses per second, right? So obviously, if I have more pulses per second, my inner pulse interval is going to be less, right? So I'll have a longer inner pulse interval, which is just to say that there's a longer pause between pulses, successive pulses. And if I have, like, let's just say 5 pulses per second, my inner pulse interval is going to be longer than if I have 80 pulses per second. That should make sense intuitively. And then amplitude, we also call intensity. So that's the magnitude or the intensity of the current, and it's usually measured in milliamps. So that's typically what you're going to use, milliamps for the most part. But that's the height of the wave. That's the height of the pulse. How much electricity, what is the intensity of that electricity being delivered? Okay. And then your frequency is straight up number of pulses per measure of time, typically measure it as 1 second, right? So how many pulses per second? Frequency is also known as pulse rate. I know it's confusing, guys, but you'll start to get this over time. Frequency, again, how frequent are the pulses, or what is the rate of the pulses? And this is always done in pulses per second. So we can see here on the chart, we've got 1. Here's a 1 beat, 2 beat, 3 beat over 1 second. That equals 3 pulses per second, right? Now we got a 9 beat over the same period of time. That increases to 9 pulses per second. On-off time, straight up. You guys know this already, right? How long is it on for? How long is it off for? It's akin to duty cycle for your ultrasound. And then the ramp up, ramp time. So we've got our on time in general, which is, here's our max on time. And then the ramp up time leading to that max on time, and the ramp down leading to that max on time is at the tail end, the front and the back of each on and off time, right? So how long does it take to go from 0 to full stimulation? And then how long does it take to go from full stimulation back down to 0? So it could take a 3-second ramp where it goes from 0, here it is like at a low level, and then it's gradually increasing. That's second number 2, and then second number 3, and it gets to your full on time where it's reached that max intensity. And then it derives based on its pulse width, how long that's going to be. And then as it pulses back down or starts to descend, it slowly, gradually lowers in intensity, right? So then it gets a little less, then it gets a little less, and then it's off, and I'm into my inner pulse interval, right? There's ramping. It's called surging, right? It's the time that's needed to reach maximal amplitude during the on period, okay? And this is useful for muscle contractions and stimulate a normal contraction. Ramping up to a solid quality contraction if I'm using my NMES or my Russian. So it ramps up. That's the way the nice thing about your ramping is it's going to make it more comfortable for your patient, like we talked about. Like, I don't want to just electrocute them straight up with like less than 1 second ramp. Usually I want to gradually introduce them to the stimulus over a course of maybe a few seconds. The flip side of that is I don't want to make it too gradual, or I run the risk of the muscle or that nerve, that neuron that I'm trying to impact, accommodating it to it before I actually reach max amplitude. So if it takes too long, by the time I reach max amplitude, the nerve will have already accommodated, so I'm not going to get the benefit that I want. And then obviously you're documenting, right? Treatment area, patient position, stimulation parameters, where'd you put the electrodes, how long was the duration of the treatment, and how did the patient do with it? So there's your intro. That's a little bit longer, but hopefully this serves as a good study guide for you guys. I'm going to get a little bit more into stuff for your quiz, particularly when we get into the next couple PowerPoints, but hopefully this was useful for you, and I got the next 2 coming your way right after this.